Thank you very much. In some ways, you represent speakers, but you also represent some of the audience. What we really want to do with this section is spend about 25 minutes just getting a round robin on some answers to some questions that I have written down, that you may have seen, but really it's about having a dialogue. Because in these events, we're in the danger of speaking at people rather than with people. So in that spirit, what I'm going to do is just say some questions. And if you want to answer, raise your hand. But otherwise, we're just going to go through. And I will start at the far end since you've been speaking just now. So to kick off, both the NHS and private health sectors want to increase their digital transformation. So what examples of innovation can you share that are driving this change? And so, okay, I'd like to take it. And actually, before you speak, first time, say who you are and what you do, please.
Okay, thank you. So you can hear me? Yeah. So good afternoon, everybody. My name is Mark Harmon. I'm the Chief Strategy Officer at eConsult, which is a digital triage company, and also an A&E doctor working down in South East London. Nice to meet you all. So answer to the question, I think it's a massive question, so I'll try to be short, but I think we're living through very exciting times, if you disregard even the mini budget of the last few weeks, but from a digital transformation, and I think as a doctor, really exciting. And I don't know whether any of you have read Eric Toppel's book recently called The Creative Destruction of Medicine, but it talks about we're living through this super convergence moment where everything's coming together. So technology, iPhones, the power of technology in your pocket, genetics, genetic profiling to ascertain disease propensity and drugs, whether drugs will work, AI, data, all the stuff that's been talked about this morning. And it's going to totally transform the way we deliver healthcare over the next sort of 10 years. And it's going to be, as a doctor, it's going to be incredibly exciting, and it's going to be incredibly scary and challenging at the same time. But I think just about innovation today, just simple things are happening today that, and I think COVID has really accelerated the adoption of technology, because there's two ways the NHS can fix the problems it's facing. One is get more nurses and more doctors and more people. That's not going to happen quickly. The other option is actually look at technology to see how we can make better, faster, more accurate decisions and improve health outcomes that way, and obviously system efficiency. I think COVID is a great example. I was working in A&E and through COVID, and x-rays of COVID patients' lungs are absolutely useless. But an ultrasound is really, really key in diagnosing COVID in the back of an ambulance before you then push patients into A&E. Historically, that was through a big ultrasound machine. For those of you who've been pregnant, you'll have seen those big machines. Actually, through COVID, we had a Butterfly, a very small pocket-based ultrasound machine that I plugged into my phone, took in my pocket, and I ultrasound scanned patients in the ambulance literally within minutes. That's just a small example of the way technology is moving, how fast things are moving. Point-of-care blood tests. Historically, blood tests have taken 24, 48 hours to come back. Now you can do them at home through a finger prick. So there's lots of really exciting stuff. I could talk about it for hours, but I'm not going to. So.
But that was very comprehensive, Mark, and I really appreciate it. I'm going to ask for one more answer. Actually, Wendy, could I ask you to respond to that? Do you want me to repeat?
So I'm Wendy Parks. I run the UK health tech business for Amazon Web Services, which is the technology arm of Amazon. So probably a lot of you don't know what we do in the healthcare space, but we work across all of the regions of healthcare. So we work with the Department of Health and Social Care, the ALBs, we work with genomics and research agencies, and we work with regional and devolved healthcare entities as well. So ICSs, trusts, PCNs, etc. I would say that we attempt to drive transformation and change across all of those areas. I think a few that I want to call out specifically are we've done quite a lot of work with Genomics England on the genome sequencing project, where we're looking at sequencing 1,000 genomes to try and identify cures for rare diseases effectively by making those data sets available to researchers in a secure and accessible way. And we also have done quite a lot of work in the ICS space as well. So the ICS is, as you know, the 42 entities in the UK English market are trying to drive change across how healthcare is delivered from a trust perspective as well. We work quite consistently in there. In fact, I've done some work with InterSystems in there as well in Northwest London. But I would say the area where I see the most innovation in healthcare is actually in the health tech business. So I work with a lot of startups in healthcare. So people, a small startup I've worked with is one called See the Signs, who use AI and ML to detect, for early detection of cancers actually. And they use modeling techniques to look at trends and clinical outcomes to try and predict where a cancer might persist going forwards. And I think they've seen an increase in about 12.7% in some of the, there's some London trusts that use the technology. They've seen an increase in detection rates of about 12.7%. And then there's another little startup I work with. It's called Birdie, and they are looking at elderly care. So preventative treatments early in elderly care to stop falls, etc., or to stop, ongoing Alzheimer's, dementia, things like that. And that again is AI ML based interventions to look at preventative care for elderly, which is really close to my heart actually, because I have elderly parents, a lot of us do as well, and you can see the strain that the NHS is under at the minute, and anything like that really helps as well. And so the startups are a really good example of where innovation is leading change, and we also innovate alongside. We have 4 kind of key go-to-market pillars in AWS Healthcare, and it's all around the ICSs, digital front doors and enabling a patient digital front door, trusted research environments, so providing that data set for analytics to researchers, and then next generation hospitals as well, so where we're using IoT and devices, etc., for improving healthcare as well.
Thank you, Wendy. So Amazon, very comprehensive engagement in the market. And of course, it is a systems approach, isn't it? You can't always take individual areas and expect to make the kind of progress that we need. However, saying that, when you look at particular cohorts, Tom, I know I've heard you say, you actually change the process. So it's not just the technology, it's the workflow and process. Could you just share something, and don't forget to introduce yourself?
Yes, I'm Tom Sawyer. I work with Cognitivity, and we're a small company that has developed a way of testing brain function, basically, but to do it quickly and easily. And actually, just Mark touched on a piece of technology which we think is very equivalent. And that butterfly thing is amazing. The fact that you can take a technique that previously would have meant going in, or involving a lot of equipment, a lot of time taken, and use it at first engagement. And then that allows much better clinical decision making. And that's very much where we see us. And I think that's a very important point in where innovation is coming in, that these tools are made available. Now, they are not always easy to, if you have a tool, to have it in there. And I think, particularly in places like the NHS, this is a challenge. But yeah, look, I think this is a very, very important area. And there are these things there. The trick is to pull them together into pathways to enable the information to be accessed. And I really think the sort of digital front door thing is a very important element of that, is also bringing the kind of engagement closer to the patient and doing more there. And that's really, really important. So that's very much what we feel we are involved with.
And I love the fact that you bring up the opportunity to diagnose Alzheimer much earlier, because dementia, when caught early, there are techniques and processes. So that early preventative move, we want to move away from break fix. We want to move to a much more engaged and proactive healthcare system. So that's really important. But James, how do you encourage innovation? So I'm moving on to the next question. How does your organisation encourage innovation and transformation of health and care?
Thank you.
Just remind people.
So I'm James Reed. I'm a consultant psychiatrist. I work in Birmingham, actually, with the Mental Health Trust there. And I've been involved in sort of digital health leadership, sounds a bit grand, of one sort or another for quite a while now. Trying to build innovation in organisations, in the NHS and everywhere, I think, is difficult. One of the first things I think you have to do is to solve the obvious problems, and some of those problems are more easily solved than others. And I think most of us now have been on a journey somewhere around doing simple things, as it were, like putting electronic health records in. It's not that long ago that, and there are still trusts out there that still operate on papers. You have to put the building blocks in place, and you have to do the slightly more difficult things like prescribing systems and so on. So you've got to give the basic infrastructure to work off. And I mean, I suppose I don't even think you'd regard those as innovation any longer, actually. They're just the essentials. But once you've solved the easier problems, of course, then you're left with the difficult problems, and they don't go away. And in fact, they tend to get larger because they're the main problems that are left. And it's at that stage that you need to get the workforce at large actually to start thinking about the tools that you've given them and how best to apply them. And that's when also it starts to shift from being about technology to being about people and process and ideas. I think that's the other thing I've come to realize. I think when I started out in this world, I suppose I took the field of dreams principle. If you build it, they will come. But of course, they don't tend to. And you have to get them to, the people on the ground doing their work to rethink. I think Wachter talked about reimagining work. And you have to get people to think about how these tools that you've given can be used in an innovative way to make the work they're doing better. And that's really challenging. It's easy when the technology is not there to say we need the technology. Once you provide the tools, it's actually a more difficult job. But that's where you actually need to get the people doing the work engaged and involved to think about how they can do it. And we've been able to do that. Just one example with a project on our inpatient units. Psychiatric inpatient wards have not been very well served traditionally by the software that's out there. So we were able to get a group of nurses together to define the various problems that they had, look at the technology we got available and build bespoke solutions. And it's gone from starting out with observations to being now a pretty comprehensive solution for psychiatric inpatient care. Now, no one else has really done that, but it's been a great example of getting staff to think about the tools, think about their work and come up with something genuinely new.
Thank you, James. I'm actually going to ask the same question of you as well, Paul. So how does your organisation encourage innovation and transformation, given that's your role as head of innovation?
No pressure. So I think it's really interesting talking about the amount of startups and new innovations that are happening generally, as we spoke about earlier, and I've had the pleasure to meet a few of those startups, which has been great. What we saw, so pre-pandemic, 2019, saw something like £8 billion of global investment into health technologies. Over the next 2 years, it was something like 82 billion. So it just dramatically increases tenfold. Why? Well, we were obsessed with our health and well-being suddenly overnight, thanks to COVID. So what we've had is a lot of external money coming into healthcare who don't necessarily understand the priorities of any particular institution. So my door is knocked on by a multitude of different startups who all have brilliant ways of solving problems, but they haven't quite known where to pitch to within the organization and know us and know the people on the ground. So therefore, yes, you've got a great idea, but guess what? It doesn't quite get traction because the time isn't quite right. And people are learning this, and this year has seen, I believe, 25% decrease from the first quarter, from the last quarter of last year, saw the first dip in this investment as external investment has started to kind of get a bit wary that it's hard to get into healthcare for these particular nuances that we have. But as such, that learning is coming true. And I'm sorry, also, we have big giants like Apple and Amazon who have failed so far after millions of investment to try and get into healthcare, apart from Amazon Web Services, of course. But other previous pieces in terms of delivery of actual treatment, it's a whole new ballgame. I think it's really interesting to see how that's now leveling. It's becoming a bit more known what's going to be working and then also how to pitch these things. So I think in terms of how we deal with that, we make that very clear in terms of our partners, what we're interested in now and where we're looking to get to in the future.
Thank you. And I actually repeat that question to you, James. And when that side of the panel proposed innovation to you, what is it what's your listing out for that says tick? And actually, what are you listing out for which says, cross, I'm not going to go? So give us an insider.
And again, obviously the first, and this is true when anyone brings ideas, is thinking about, like you said, about what is the problem this is due to solve. We have had lots of people come to us with lots of nice ideas of things that are interesting or good bits of technology, and that's great. But we have to find a clinical service problem that this is the solution to if it's going to work. Because we have unfortunately followed down and gone on a few rabbit holes trying to make a piece of technology fit somehow into the organization because we thought it was great tech, and it was, but they just didn't really address, if you like, a business need. And so what I'm trying to do at this is sort of both sides of it. We're trying to get out and listen and see what's out there, but also we're trying to listen to our own staff as well and pick up from them where their real pain points are. So ideally, what you're looking for is an alignment between what the companies want to do and where the needs are. I think it's difficult sometimes, a bit like you say, for startups and things, because they've got exciting ideas they want to pursue, and that's great. But sometimes the problems we face are not very exciting problems. They're quite simple, difficult, but but they're not the sort of thing that a fancy piece of technology will solve. So I think it is a bit tricky. And I have had to say to a few people, well, that's a lovely idea, but I just can't see how that really will help our particular staff. So I think there's about a dialogue between ourselves and industry, and understanding each other actually, and make, because it would be a shame if people got disheartened by spending a lot of time and effort and money into something which they then couldn't sell. And I think I've seen that happen in a few cases actually, where the NHS is seen as a very difficult person to do business with. But I think if you can understand what the needs, and there are examples of companies that have done very well at this actually, you can understand the needs of the business and provide solutions that meet those needs. That's the best way to do it.
Okay, so focus on an organization's purpose, focus on the needs of a real problem.
Yeah.
But even when you've got that, such as dealing with dementia and the early diagnosis, Tom, how do you actually still overcome the barriers to that change? Because it is, as we've heard through other speakers this morning, a change in the way people approach what they're doing and way they can reframe what they're doing. So how do you get past the no's?
Yeah, it's a really good question, and it's very encouraging to hear, because I totally agree with both the previous points, that both for the organization that you're trying to get into to be able to communicate what their problems are, and for you to shift the way you think about it, because it's very common for founders and startups to have a wonderful idea and they're very kind of set on how that should change the world. But I think the way to deal with it is all around that, really. You have to have a real problem. You have to engage with it and go for it. I think the challenge that we often find is, like you say, Mike, if what you do requires a slight change in behavior by the people that are doing it, that's always harder, because they've always done it this way, and do they have the time or the resources or the sort of the willingness to reframe the way that they tackle this problem is actually quite challenging. So you can be going, oh, this will totally solve your problem here, and they're like, yeah, but we've always done this, and why would we do that? So I think that's a big one. But I think that it's always been like that. I think that the potential customer can very much help with that by allocating time for this, doing a pilot that's meaningful, that's well designed. And again, that's incumbent upon us to feed into that process. So it's a challenge, but not insurmountable, but communication is massively the key.
Thank you. Sorry.
Just to add on to that, Mike. I think, and that's where particularly in sort of healthcare organisations, you need to have the support of the senior leadership to actually make it okay to do that. Because often I think people in teams at ground level don't necessarily feel empowered to do that. It's difficult. And so you need, right from the board downwards, to be able to be providing permission and encouragement and support to do exactly that work.
And I think that we have an opportunity now to include the service users, the patients, in the process. There was a great story, I think it was from the Northern Care Alliance, where they dealt with some homeless people, one particular, I think his name was Stephen, and the key to changing that person's behavior was sorting his teeth out first. So he had a lot of problems with his teeth, getting the teeth sorted, getting him clothed, getting him in, and 6 months or maybe a bit longer, he was back working, being productive and feeling a lot of self-respect. So we've got a chance of changing the whole process for people. But when you do have discrete solutions such as triaging in an ICS, the way resources are being used, particularly maybe the emergency department, Mark, dealing with those incoming patients, helping to prioritize and triage, how are you finding overcoming that? Because you're working across different care settings and care providers. So how does that cultural change happen, Mark?
Yes, good question. So I think it's difficult. Healthcare is complicated, as we know, and the NHS is incredibly, even more complicated, for the right reasons in many cases. But I think when we started life as eConsult, probably 7 years ago, we were born from the NHS, set up by a group of doctors, and we thought, this is great. We've landed on something really, really special here, and actually it's a software as a service model. So actually we do the software and we just sell it. Great. But actually it's the last S that's more important. It's a service piece, which is much more important than the software, because actually the software bit's easy. It's the cultural change. So actually, a large part of our organisation now is people, operations, transformation, customer success teams, working with our customers. And to James's point, I think we need to engage both the top board level, because obviously you need to get the buy-in and the business case, etc. But it's really key to engage the users, who's going to be using the product. So for me, it's very much it's clinicians at the pit face, that are feeling the pain every single day, and it's trying to get them on board, win their hearts and minds, to show actually this technology, because it's quite scary technology, because a lot of people think actually this is potentially going to replace what I do. I've been doing this for many, many years. I don't want to change, and particularly NHS workers who, work mainly on goodwill, certainly not for money. They're worn out. They don't have time to breathe. They don't have time to reflect. They certainly don't have time to train on new software or even think about that. So it's taking time to understand, to have really deep insights of the marketplace, because the NHS is incredibly unique in the way it operates. So to have deep insights, what those problems are, what the pain points are, and in working with people, because ultimately people actually are the barriers, but people are equally the solution as well, because they're the people on the ground are going to be the people who make something work. We've got experiences in the past where we've gone to practices, we've gone live with product, and actually people haven't engaged, and it just hasn't worked. Whereas we've worked with practices that are open to change, we've worked with them, we've given them insights, and actually the technology has been amazing. So I think a lot of it depends on that transformational piece, that human element as well.
I remember back in the early 80s, I was connecting a VT100. If anyone remembers what those green screen terminals were, there you go. And I was in medical records, and I'd wired it in. I was very happy with it. I went away from it, came back, and they'd unplugged it to plug in the kettle. And that told me how important what I was doing was to them. And that's true today. So, Wendy, how do you do it when you've got this vast panorama of Amazon services that are really reacting to this consumerization of health and care? Paul touched on it earlier, really, because what you're changing with Amazon is not just the technology, but the whole possibility of delivering consumption by the people who need it. Mm-hmm. So how would you look at the barriers and the adoption of cultural change when we're talking about moving the boundaries of health and care forward?
Yeah, it's a recurring theme, actually, and I think the best ideas from healthcare come from clinicians on the ground, and one of the problems I see repeatedly is being able to scale an idea and take it into a productionable solution, even if that's just within a trust, or to go multi-trust across an ICS, or in your case, to launch your own startup and take that product to market. So we've put several programs in place to try and help people do that. We kind of see ourselves as enablers in that space. So we've set up startup accelerators to help launch startups. We provide advice and guidance on navigating the funding processes. We advise and guidance on pitching to VCs, et cetera, et cetera. We also run a health tech community event where we deliberately introduce health techs to health techs. So a lot of the big health techs that work in the UK market have a product strategy that is not acquisition, but it's plug and play with smaller health techs. So we make a point of making those partner-to-partner introductions as well. And then we have a partner ecosystem that's very strong. So our partners are either technology partners or services partners. So we will deliberately introduce niche services partners to the likes of InterSystems or yourselves that will work with and listen to what the concept is working backwards, we call it in AWS. So we identify the problem first and foremost, and then we work backwards to identify what the right solution is. And we always do that from two specific lenses. We always look at it from a patient experience lens, and we always look at it from a clinical outcome lens. And those are the two kind of filters that we put on what we do to try and make sure that we are connecting and aligning and driving the best outcomes. But it is difficult, I agree.
That working backwards, I think maybe I heard it attributed to Amazon, but that phrase of what does success look like? If you can focus people on that, then you can work backwards from it. Mm-hmm. And actually, as you say, go through that clinical and commercial and technical process. Because, the best of EPRs that you have won't work if you can't get access to it because you don't have Wi-Fi. People, if they're not familiar with digital technology, or they're possibly going to be on the wrong side of the digital divide. So how do you bring them on so that they're fully included in this new world that we're trying to pioneer? Are there questions from the audience that you'd like to place? And I'm not just looking at Integrella, but they are active. There is a question further back. So do we have access to microphones, or have I caught people by surprise? Because I think we've had very full and very clear answers. But again, like I said at the beginning, it'd be good to get the audience involved. So don't forget to say your name and company, please.
Yes, good morning. My name is John Peck from InterSystems. Actually, I just want to tell you an incident that happened to me in the last 3 days medically. We had an incident, fortunately, at my home. I had to ring 999 and tell them I needed help. And then they said, "Did you have a smartphone?" I said, "Yes." And they said, "I'm sending you a message, click on it, and then we'll use your phone to look down the throat of this person, and we can then examine what is wrong with them." I thought that was innovation pretty interesting.
Yes, thank you,
Mobile
John.
phone was used for that person somewhere in London to do the examination instantly.
Yes.
And I thought that's an example of more or less what you're talking about.
It is. It's a good practical example of how someone is using it. It's like the famed ambulance worker who talked about ICE, that contact in your contact books of the emergency contact information. You know, I don't know whether it's still used now, but the idea that we're making things easier to do the right thing. For me, certainly, what you guys are doing are taking sometimes common sense, but making it easy to happen next. Because when we're under pressure, we don't always make the right decision. Or at least I don't. Anyway, you saw that earlier today several times. Any other? Yes, we do. We have 3 questions. I'm going to leave it to the person with the mic to try and find them, and we'll start at the middle. Okay. Don't forget your name and organisation.
Thank you. I'm Paul Bevan. I work for Bloor Research, which is an IT analyst house. Really, it's about how do you propagate the innovations more broadly within the NHS, given the sort of very, very fragmented nature of the structure and the buying process. It seems to be an organisation that doesn't pick up on the innovations particularly easily. So what mechanisms do you see to help get these innovations out more broadly to people who haven't heard about them? Okay,
so repeat and scale. That's the thing. I'm going to go to James first. How do you repeat and scale innovation?
Thank you. Yeah, it's a difficult problem, and I think it's because a lot of, as everyone knows, really, people think the NHS is one organisation rather than being a kind of a franchise sort of authority where you have lots of individual organisations underneath, and that is quite difficult. So you can't really sell anything to the NHS as a whole. Although what you can, of course, do is promote sharing of good practice and assisting organisations in supporting others doing similar work. And I'll talk about this afternoon, but we have seen examples where, a particular region has done something and has been able to, by talking about it early, such that, you can intervene at the right moment. Because the worst thing that can happen is different organisations are at different stages of, say, a procurement journey and just don't know what other people have done early enough for it to be able to have an impact. And the other thing I suppose I would say, which is the other way around really, is that there are barriers, and regulations are certainly barriers to some degree, particularly for NHS-spawned innovation. So if an NHS organisation comes up with something, a bit like our observation platform, then you start getting into the world of medical device regulations and things. That becomes a real barrier to progress, because you can use it yourself, but you certainly can't sell it, but you can't really give it to anybody else either unless it satisfies the regulatory approval, which is very difficult and very expensive. That certainly stifles innovation and tends to hold things in one place just because you're not allowed to spread them any further, which is a real obstacle.
But we do need the rigor of DB 0129, the regulation that enforces that process of both the supplier and the user understanding the clinical hazards there. So I think we're moving forward in terms of safety, but it's a barrier of friction perhaps to that wide scale. I'd love to go to Wendy, but we do have 2 more questions. So I'm going to say, can you get the next? Yes, Integrator is always at the front, but don't forget there's one at the back too.
So sorry.
I'm going to ask you to say your name and organisation again, just out of punishment.
Shari Hake from Integrella. There's a well-known phrase that prevention is better than the cure. Can the panel comment on their perspectives on public and private investment into prevention versus investment in the cure? And is the balance in the right place?
I'm going to go straight to Paul because Nuffield will have an answer for that, please.
It's a brilliant question, and In terms of our strategic aims, which doesn't have a timeline currently, but it is certainly a move towards capitation is a strategic aim for us. So making sure we're all talking about the same thing. The idea that you would pay a private health organisation like Nuffield Health to look after you end, right? So whether you get ill or not, the fee is the same and we will treat you. So therefore it's in our interest to prevent any major illnesses or any other accidents even happening to you as a member of our organisation. So how do we start pushing towards this? We are heavily investing in preventative services, and hence why we have that connected service that tries to look after all of your well-being cradle to grave. The proof will be in the pudding, whether we can link that together technology-wise as well. But I think it would be nice to know if all organisations were going towards that kind of strategy.
Certainly, Jeremy Hunt had a very strong feeling when he was the Health Secretary about funding things that would have a massive change. So not trying to cultivate the field of 1,000 flowers, but find the things that would make most change. And talking about personal and transactional budgets. So it's not just I break my leg, but it's the fact that I'm overweight and I haven't got the lifestyle. So what are those budgets? So interesting. I'm eager to go back to the back of the audience. Yes. Don't forget your organisation and name, please.
Neil Ahead from Daedalus Healthcare. I've got two questions about accessibility. One is for remote and rural communities. How do you see the innovation we've been talking about making healthcare more accessible to 100% of the population in the UK, not just those who live in the population hubs? And the other is about people with social anxiety who find trips to GPs and hospitals scary. How do you see the innovation making healthcare more accessible to them?
Okay, I'm going to go to Wendy and then Mark. So Wendy, would you like to, about accessibility and about dealing with the people who have anxiety?
So I would say that both of those things are really important when looking at any kind of delivery of healthcare, particularly anxiety. There are solutions that are fit for purpose for teenagers who have anxiety. It's an increasing problem. There are solutions where it's not appropriate to put a video call in front of a teenager and make them more anxious. So I think that when health techs and solution providers are addressing solutions for those markets, they do think about those kind of things. There is more of an awareness, I'd say, now from a diversity perspective. There's also a better view on health equity as well, which is not only a regional issue, but an issue about access from network access and all the rest of it. And there are lots of technical solutions to things like that. I'm not going to bore you, and it's not product pitch, but there are AWS outposts that you can put in rural locations to increase connectivity. Those kind of things happen and are being discussed at a regional level. There's lots of initiatives happening regionally as well from a procurement perspective to try and improve accessibility for some of the devolved regions. Like there are national procurements in Wales, national procurements in Scotland that address some of those issues as well.
Thank you, Wendy. And Mark, again, you're dealing with a regional provision of care services, and you're trying to augment the services that are there already. You're not necessarily trying to replace, you're trying to extend and improve and reinforce them. So how do you go about making sure that accessibility is there, but also that we don't fall foul of that digital divide as regards anxiety?
Yeah, it's a great question, I think, because digital obviously is set up potentially to solve some of the issues we have with remote care. Particularly in general practice, we're seeing a lot of remote practices that are closing down, unfortunately. So if you can, remotely consult with your doctor online, it'll save you a trip and, it'll increase your access. But certainly at eConsult, we're acutely aware and attuned that digital isn't for everybody, okay? And there are patients who are not digitally adept, don't want to engage in digital, and that's absolutely fine, and that's absolutely right. So I think a blended approach is where it works really well. And what we're seeing actually, for a general practice, an average general practice using eConsult, about 70% of traffic is shifted online. So what that means is actually access into the practice for patients who are not online is improved. And we work through transformation teams with practices to identify those high-risk patients, so those digitally inept or unable patients, to give them a direct access into practice. So the philosophy is if we can shift the majority of the simple traffic online, we actually free up other routes in. And on the social anxiety aspect, again, this is really interesting because there's not an age barrier either, which again is quite surprising when you look at some of the data. But some of the silver surfers are more adept than I am. But the anxiety piece is really interesting because certainly what we see, about 30% of digital consultations are for mental health. And that's also in A&E, that's not just in primary care settings. And the interesting feedback we get from patients and also from clinicians is actually patients with anxiety, mental health problems actually sometimes or often find it much easier to consult online, where they're not under pressure, they're not under time pressure, they're not having to give eye-to-eye contact, they've got time to think about their responses. So actually from a clinical perspective, the clinicians tell us that they get a much richer history than they would potentially have had in a face-to-face consultation. Be interested to see what James thinks, but it's so it's not all negative, I think, from a digital perspective. But I think the important thing is equally it's everything shouldn't go digital. It's a blended approach, and it's trying to get that balance right so we can get maximum effect for everybody.
James, did you want to comment?
Yeah, I think what we've learned from all this is I think historically, if you'd have asked me or most of my colleagues, would have said, no, a face-to-face appointment is the gold standard. That's what we must have. But I think I've come to realize that's absolutely not the case, just like you say. And in fact, face-to-face appointments discriminate against people who don't have transport, who have difficulty with one-to-one interactions in rooms and so on. And we actually found, especially early on in the pandemic, lots of people were saying to me that they've had the best consultation they'd ever had with their patients by, say, a text message exchange or a WhatsApp call or whatever. And I think what we need to now say is we have a range of methods of engaging with patients available to us, and all we have to do is select whichever one of them it is we think is the most appropriate for that interaction. And some of my colleagues might still say, well, you can't do a proper psychiatric assessment over a video call. I don't really agree with that, actually, I have to say. I think it depends, of course, but there's nothing intrinsically about any particular means that makes it, the wrong thing to do. And as you say, if you get better engagement because the patient's more comfortable with it, you're probably going to get a better assessment.
So I'm now going to ask a difficult question, and it's deliberately difficult. It's the end of the session. I'm going to ask you to think about what innovation will look like in 5 years' time and what role you'll be playing in it. So I'm going to start off with Paul. Just 5 years' time, let's dream.
As I said in the speech, I think AI in terms of diagnostics, I would hope would be every day for certain issues, including skin issues, even coughing, being able to record your cough and therefore diagnose what kind of flu you might have, COVID. I don't know if anyone's seen it with this technology, very much in its infancy. But I definitely like the idea of being able to put diagnostic tools in the hands of patients directly at home. And I'd like to see that grow as soon as possible.
That's a wonderful example. Tom?
Yeah, well, I'm going to be inclined to agree with this, and there's been some good points raised there. But I think it is about having a selection of tools which can answer questions both for patients and clinicians being made available in a selection of ways. So you can have this much more personalized interaction, much more personalized information gathering to enable personalized diagnoses and treatment to be done. And I think that's what it is. The bits are there. It is about pulling them together and making, again, a change in attitude. But the tech is kind of getting there. It just needs to be pulled. And
Tech's not so much the problem. Mark, 5 years' time, where will you be changing healthcare? Sounding American, I'm sorry to all the Americans, I do it badly.
I used to work for Nike, so I'd like to have the just do it attitude. But I think that in healthcare that's quite difficult. But I think I use a cancer example because Wendy used it earlier. But so in 5 years' time, I'd like to think actually patients are being picked up by an algorithm, detecting their symptoms and the nuances and subtle signs and symptoms that would diagnose cancer at stage 1, stage 2, rather than stage 3, stage 4, and route straight in to a 2-week wait pathway to the correct oncologist, immediately on hitting the button submit with the correct test results in place. Because at the moment, 26% of patients are diagnosed on a 2-week wait pathway. We've got some of the worst cancer detection rates in the G7 nations. and we can use technology to speed that up. And for every week we save in diagnosis, we increase the prognosis by 1%. So if we can cut 4 weeks out of that pathway, it currently takes 5 GP visits on average to be referred for cancer. If we can save 4 weeks, you increase your prognosis by 4%. And if we can diagnose at stage 1, stage 2, as opposed to stage 3, stage 4, we can save an average £13,000 for every patient in terms of cost of treatment.
So it's making it more affordable, not just a better outcome and better experience. James, how would you see yourself with your finger on innovation in 5 years?
Well, I'm going to set a sort of fairly lofty ambition, and I would like to think we could be running services that use the tools available to ultimately base around the individual needs of the patient rather than the practical considerations of the staff. And I think, unfortunately, that's still the way our services are constructed, and it will need us to think entirely differently. But we have, I think, finally now largely got the tools available to do it. And so I would like to be working in a service that was doing that. Now,
thank you, James. Big technology companies come into healthcare, but do they stay the path? I've been in this industry 42 years now. Amazon, have you got the strength to stay that line? Because in 5 years' time, the world will be a very different place, especially for Amazon. But will you still be in healthcare, and how will you be changing it?
I hope so. I hope I'll still be in there. I hope I'll still have a job as well. Yeah, we'll definitely be in healthcare. We've been in healthcare for years now, and there's an absolute appetite to stay in and try and help drive improved clinical outcomes. And I think, to your point, not only just from a UK perspective, but from a European perspective as well, and also taking some of those clinical initiatives into social care. Like we've talked about, there's so much we could talk about in this area, but the example that the gentleman gave about a clinical triage using his phone, that I've seen that in action. It's amazing. But there are other parts of society we can take that into as well. We can take that into elderly care homes. We can take that into prisons. There's so much to do and improve on. We're in for the long haul, definitely.
I love that. So we're in it for the long haul. I think all of us are in, or at least I hope that we are. Thank you very much. A round of applause for our panel.